Awesome. Okay, you guys ready for some science? All right. After my presentation, I know that it's lunchtime, and I'm sure it's going to be delicious because we were at Nathan's home last night, and they prepared a wonderful meal for us. However, I am not going to be able to... What's this? Oh, thank you. I'm not going to be able to stay for lunch. I'm going to tell you a story. It's actually funny. So my son, he goes to a school that is early childhood all the way to 12th grade. He goes to a private school. And this summer, I took him there for a mad science summer camp. He's 7. And he's like, and they were having other camps, and they were having a cheerleading camp for the first graders. And so he's like walking in, going to his mad science, and he's like, he sees the cheerleaders. And I was like, I saw an opportunity, and I said, oh, Wyatt, you like those cheerleaders? You think they're pretty? And he was like, yeah, Mom, they're beautiful. And I said, well, guess what? Cheerleaders don't want to hang out with people that eat their boogers and can't spell cat, okay? So I have been using those cheerleaders since then to get my son to study. And today, there is a pep rally at his school. It is the first football game of the season. It's the home game. And I received and he's so excited. And I received an email last night that the lower school would not be attending the pep rally due to increased precautions. However, since we pay the price of a Ford Focus to send our child to first grade, if we wish, the parents can come and escort their child to the pep rally. So after my presentation, I'm going to ditch you guys and haul ass to my son's school so that he can see some cheerleaders. It's not that I don't want to stay here. It's just I need those cheerleaders because I'm using them for my parenting skills, okay? All right, so today we're going to talk about implant placement and avoiding complications. It's funny because originally I was going to talk about complication management, but quite honestly, like if something goes wrong early during implant placement, you're just kind of screwed. And anybody that places implants knows that. So how about we avoid them? So we're going to talk about that. You all know where I'm from now, thanks to Dr. Abernathy. I'm from Amarillo, Texas. This is about what it looks like. It's very flat. You can see far, long ways. The wind blows very fast, and there's no trees to block the wind. In fact, when I was 8 years old, I actually blew away, and I survived, but it's a true story. There are also some really great things about the Panhandle. Hands down, we have the best sunsets and the best thunderstorms. Maybe you guys have some good ones in Oklahoma, but you can smell the thunderstorms. There's nothing like it. Like you can smell them coming into town, and whenever I go back, it's just very nostalgic for me. If you do happen to go to Amarillo, I highly recommend that you go to Palo Duro Canyon. It's like a mini Grand Canyon. If you've never been there, you should go. They even have a musical there that's performed outside, and it's been running for over 50 years. It's called Texas, and it's the history of Texas. You go to Palo Duro Canyon. It starts around 6 p.m. You get to eat all this barbecue, and then you watch the show, and it's really cool. So I highly recommend visiting Palo Duro Canyon. I went to college in Austin, Texas, a small private school down the street from University of Texas Longhorns, so nobody knows where St. Edward's is. But so we have to say things like, I was a tour guide there, right, because I'm a model student, and I would have to say things like, this is St. Edward's. We are on the highest hill in all of Austin. Like, those were our selling points. But it was a great school, and I got to live in Austin, and that was awesome. Then I moved on to get my DDS from Baylor, which is where I met Nathan. He was a year ahead of me. I joined the Asian Dental Society. I have no idea why I joined the Asian Dental Society, but I did. It's because Dr. Lulu Moore said, join the Asian Dental Society. And I said, but Dr. Moore, I'm not Asian. It's okay, baby. Come on. It's okay. It doesn't look like this anymore. This is what it looked like when I was there. They have a beautiful building that they built last year, and it's now called Texas A&M College of Dentistry. I need to go visit and take a tour. I haven't been back in a while. I go back and I get like, my stomach goes into knots, you know. I bought a practice. I finished residency from Baylor. I stayed there. I finished in 2012, and I bought a practice in Fort Worth, Texas, and that is where I work, and I love it there. I couldn't have landed in a better spot. Please, if you're ever in Fort Worth, shoot me an email or a text. I'd love to show you around. It's where the West begins. My family, I have a very non-traditional family. I have one child, Wyatt, and he's 7, and he did graduate pre-K, so that's goal number 1. And then my sister is in the picture with him, and my sister actually came to live with me when she was 12 years old. And so she is now 23, and she's about to graduate with her master's in speech pathology. So I'm going to go ahead and take credit for that also. Thank you. All right, so full disclosure today, I am not paid to talk about any products. I'm not on anybody's payroll. And in fact, any honorarium that I ever receive for speaking, I donate to a charity. The charities I donate to have to do with animals or children, usually. And the charity that I will be donating to today is called Fort Worth Spark, and it's in East Fort Worth, and it's in a zip code 76105. It's basically the worst zip code in Fort Worth, District 2. These kids are safer in school than they are at home, and so last year was a big issue when the schools shut down. But so they're getting the money today, so some of these kids can do summer camps and fun stuff with Fort Worth Spark. Okay, so I would just like to survey everybody quickly. How many of you guys would consider yourself, when it comes to dental implants, a beginner? Maybe you've never placed an implant, or maybe you've placed less than 10, you don't feel comfortable giving advice on implants. Okay, a lot of you guys, okay. What about intermediate? Like you place some, you refer some out, you pick and choose what you want to do. Okay, the smartest person in the room right there. Okay, great. How many of you would consider yourself an expert? Like you rarely have to refer out. Okay, all right. Well, the good news is what you're going to hear today can help everybody, okay? Because I bet you not a lot of you are doing it. This is my favorite quote, Henry Ford. Anytime that you're looking to bring on something new in your practice, whether it's a new procedure or even just a new way to practice, I mean, as we've heard, change is, sometimes we don't like change, but whether you think you can or whether you think you can't, you are right. So just always remember that. It's all about a mindset. Okay, so I do have some advice for the beginners. And I put this, take my advice, I don't use it anyways, because we never do what we're told. We really don't. Like, we get all this advice from our mentors, and then we just don't do it. But I'm going to tell you, and so that way maybe I can help somebody. If you want to have a happy life, start placing dental implants, this is what you do. Keep things simple. Treat all maxillary premolars, all of them. They're the easiest, highest success rate, okay? Treat the mandible. Just don't hit the big nerve that's in the bottom of the jaw, okay? The mandible is very predictable. Non-aesthetic cases in healthy patients, okay? And tissue-level implants have one of the highest success rates with the least amount of inflammation. I know they're old school, but they work, and they're not aesthetic, but we're not going to do aesthetic cases, so molars are great tissue-level implants, okay? So there, you heard it from me. Also, and for those of you that have not taken an implant class, you're going to go take your awesome implant class. You get to go to fun places like Brazil, places like that, instead of the basement of Baylor where we were. But this is what you're going to look for your first patient, okay? His name is Billy Bob Joe. He drives a 1987 Ford pickup truck. He drove 1+ hour to his consult, and he has cash in his pocket because he read all your awesome Google reviews, and he wants treatment the same day. This is the patient you want, but you're not going to get this patient. What you're going to do is you're going to treat this patient first. All of you, this is what happens. You don't take the advice. I didn't take it either. I didn't take it. This is who you're going to treat. Finally, my implant patient. Number 8, immediate placement, immediate load. Patient is Miss America with a high smile line and getting married in 2 months. This is a stressful life. And you can do this, but just get ready. Okay, So the objectives today, we are going to understand the current complications and etiologies for early implant failures. I'm going to touch on late failures, but this is mainly going to be about early implant failures. Everybody here today is going to leave with an armamentarium of knowledge and a protocol that you can start to implement that I can pretty much guarantee will increase your implant success rate by at least 1 percentage point, okay? All right, so anytime you're practicing, trying to decide a treatment or trying to decide to add new treatments, the first rule of ethics, right? Do no harm. So that's basically what I tell myself all the time. Like I get these complicated treatment plans, like periodontal patients that want to save some teeth and implant some teeth, and how do we do this? You know, so we have to present a lot of treatments, and always it's do no harm. And I tell my patients, I want you to leave my office in either the same or better condition than when you walked in. That's my goal, okay? I don't make any grand promises like I'm gonna change your life or anything like that. It's just like, I'm just gonna try to let you keep your teeth and chew your food as long as possible. So as far as the risk factors, it's important to know the risk factors because you need to inform the patient, okay? Even if, you know, there are not a lot of implant failures, but when you do have an implant failure, the patient wants to know, why did it fail? You know, that's the question that they ask me. Why, Dr. Nelson? Why? You're so pretty. Why did it fail? I'm just kidding. So what we can do is we can inform the patient. We're going to go over, if they do have some of the risk factors, we're going to go over that with them. And in my office, I go over that with them, not somebody that makes $20 an hour. I sit down with them and I go over, these are your risk factors, okay? And this is how we can change them. We're going to add techniques to minimize the risks, okay? And also, patients need to understand that this is a team effort, okay? If you break your arm, you go to the orthopedic surgeon, they're gonna put your arm in jail for 4 to 6 weeks, and it's gonna heal, and they have a very high success rate. We can't put your mouth in jail. Like, we do bone grafts around teeth, and you are chewing and brushing your teeth, and so you have to be on board, and patients have to understand what you do at home, you know, is gonna affect this treatment that you just paid all this money for. So you have to go over that. And does anybody know how many times somebody has to hear something before it sinks in? 3, that's right. So we do it at the consult, go over post-op instructions. We do it when we confirm the appointment. We do it before the IV goes in, even though they really don't remember because they're so nervous. And then I call every patient at the end of the day, and I go over it again. So they hear it 4 times. So there is no excuse. They should never be able to say, oh, I didn't know I wasn't supposed to chew on that. So, all right, so let's get into risk factors for early implant failure. Everybody knows the most common one, right? Smoking, right? So, and smoking is not cool, okay? She is not gonna look like that in 10 years, trust me. All right, so early implant failure. I do have a list of all my references, and I'm happy to email them. It's about 15 to 20 articles, and they're all really good. So I'll give them to Nathan, and you can email them out. But you guys should read these, because most of them are review articles that are great. So there was a study where they compared, this is probably one of the most quoted studies. So basically, non-smokers compared them to smokers. Most of these were engrafted maxillary sites, which already have a high complication rate. But anyways, smokers basically were 2 times more likely to have an implant fail than non-smokers. So this is great because you can say this to your patients. Okay, sir, I see that you smoke 10 cigarettes a day. I understand that's only half a pack, but did you know that if you don't follow my smoking cessation protocol, which is stop smoking 2 weeks before your implant and refrain from 2 weeks after, so that's 1 month of no nicotine, not even a patch, that your implant is 2 times more likely to fail. Just want you to know that. Put it on them, right? We blame ourselves all the time for like these complications, and we just have to inform the patient. So conclusion, I just told you guys the conclusion, is 2 times more likely to fail in maxillary grafted sites. Periodontitis, of course, is a risk for early implant failure if it's not controlled, okay? So if I get a patient that's referred to me for an implant in number 13, they get a complete periodontal exam. And I've seen some of these Facebook groups. I've seen dentists get mad. I sent my patient to the periodontist, and they came back with all this treatment. I just want them to put an implant in number 13. Well, I'm a board-certified periodontist, so I am responsible to educate them on their periodontal health. So if they're coming to my office, they are getting a complete periodontal exam, and I'm not going to put an implant in number 18 if I can help them save all of their teeth, okay? So we all have to be on board that we are doing what's best for the patient, and that's what we do. So if they do have periodontal disease, that's great. We can do implants, but we need to get it under control so that we have a great success, okay? What about diabetes? Diabetes is only a risk factor if it's not controlled, okay? So we'll kind of go over the parameters for that as well. And then antibiotics. There's a lot of confusion about antibiotics. But basically, the antibiotics, the only time that they are of benefit if they're started before the surgery. So every patient that comes in, if they have not started their antibiotics, like it says on the post-op instructions, then we give them a loading dose right there. So the 2,000 milligrams of amoxicillin. The ADA has kind of put a kink in my protocol because they don't want us prescribing clindamycin anymore because of the risk of C. diff. C. diff, they want us to use Z-Pak, which there's not really a loading dose for, so we just have to make sure those patients start their antibiotic 1 full day prior to treatment, which we do when we confirm the appointment. And then vitamin D. So everybody knows about vitamin D now after last year, which has been kind of good for me, but we've always talked about vitamin D with patients, and it's extremely important for implant integration, and I'm going to show you guys some numbers that really might even shock you when it comes to implant failure. Okay, so this is just a chart here, early implant failure versus late implant failure. Smoking, so we're going to start with early. Smoking, we're reviewing here. It's 2 times more likely to fail if they're a smoker. For late implant failure, it's dose dependent. So they are at risk for late implant failure if they smoke, a lot. The more they smoke, the more at risk they are. Diabetes, basically if their hemoglobin A1C is greater than 8.0, which is a number that I basically derived from Brian Mealy's papers. He's on staff at San Antonio, and he's written a lot of papers about systemic health and periodontitis. And so we don't do anything fancy on anybody that has an A1C over 8. No regenerative therapy. Their vitamin D. So I'm going to show you guys some data on this, but if their vitamin D is below 30 nanograms per mil, their implant is 3 times more likely to fail. That's even worse than smoking in periodontitis, okay? I'm going to show you guys a protocol to remedy that. Posterior maxilla has a higher complication rate, but we can't really do anything about that, right? If they need an implant, they need an implant. We just have to inform them of the risks. Trauma, improper surgical technique, if you're not using irrigation, if you over-torque your implant, these are problems for early implant failure. And then if we use antibiotics, we're going to be sure and start them prior to treatment, right? On the late implant failure side, I already talked about smoking. Peri-implantitis is a risk factor for late implant failure. And now they're finding that once peri-implantitis starts and you get some bone loss, the oxide layer comes off the titanium implant, and we're finding titanium particles in the tissue, in the bone. Sometimes that causes a problem for some people, sometimes it doesn't. It just depends on their immune system. If the implant has peri-implant mucositis within the first year, then it's at more risk for late implant failure. So you should see your patient. You should check those newly placed implants after they get the crown, check them within the first year. And if you see some inflammation around them, figure out what's causing it. Do you need to go over oral hygiene with the patient? Do you need to check to make sure there's not any cement there? Try to figure out why there's inflammation there, because you're going to help save that implant in the long term. As weird as it sounds, if there's more than 20 teeth present in the mouth, there's a greater chance for late implant failure, which is kind of the opposite of what you would think. If the implant is less than 10 millimeters in length and you immediately loaded it, it has a poor long-term prognosis, okay? So if we're going to put a 10 millimeter implant in, we're not going to immediately load it. And interestingly enough, if it's greater than 10 millimeters and you used a surgical guide, there's an increased risk for late implant failure. Why do you guys think that is? So I want you to, I'll come back to this, but I want you to watch this video of me using one of my surgical guides. I don't do a lot of fancy guided surgery. I'm kind of an analog girl, but I do use surgical guides up to the 2mm drill just so I can get my placement right. But watch my drill here. What do you guys see that happens that might be a problem? Watch what happens right there. It's not hitting my drill. So, very important on your surgical guides to make sure that irrigation is getting to that drill and that your bone is not overheating, okay? So, in this paper, which all of you guys have a copy of, I'll send it to you, that's what they speculate the problem is improper irrigation. Type 4 bone has a higher risk for late implant failure. So I don't do those implants in the tuberosity. I try not to do that. I'll do a sinus lift and put straight up and down implants in, and they'll just have to wait before they get their hybrid or whatever we're doing, because I try to do what's going to last the longest. And then if they have an opposing arch that is a complete denture or removable partial denture, they're at a higher risk for late implant failure, which you would think would be the opposite, but actually they do better with teeth. And then, of course, bruxism, inappropriate occlusal load, radiation therapy, stuff like that, that you guys already know about. Okay, so we did that. We already saw that. All right, so let's talk about vitamin D. So if you were to get on PubMed and read some review articles about vitamin D and dental implants, and if you were just to read the abstracts, they would tell you that there's no difference, okay? But sometimes you need to look at the article more closely, okay? And so in this article, there was no difference between all of the factors they looked at, okay? But so what they looked at, and I'm sorry, this is kind of small, but does everybody understand what the p-value is? So the p-value in an article is the significance, okay? And if it is, but even more, look at the patients that had greater than 30 nanograms per mil. They had the lowest failure rate. They had 2.9%. So why don't we just talk about vitamin D? Apparently it's important. So that's what I've been doing for the past 2 years. And I have really noticed a difference in not just the way the implants heal, but patients tell me like their blood pressure, they come back and they're like, my blood pressure is better, and a lot of things get better with vitamin D. So what happens with vitamin D? Where do we get it from? I know that you guys know we get it from the sun, right? So what happens is it's in our skin, and that we need the UVB rays from the sun to convert it to vitamin D3, okay? And then the vitamin D3 goes to the liver, and it gets changed a little bit, and then it goes to the kidneys, and it gets changed, and then it gets absorbed in the intestines. So, and it goes to the calcium goes to the parathyroid hormone and stimulates that to be released. So really, vitamin D is more like a hormone. It does a lot of stuff. And we can get it from our diet, but not really anymore, because our diet is basically processed food crap. And we don't get a lot from the sunlight because we wear sunscreen, we protect ourselves from skin cancer and things like that. And the more melanin you have, melanin absorbs the UVB rays because it's like a protective mechanism. So also you have to stay outside even longer if you have darker skin. So the American Endocrine Society recommends healthy vitamin D levels of 40 to 60 nanograms per mil, okay? So that's kind of what I shoot for, all right? And that's what our paper told us too, right? Greater than 30 nanograms. So we like to at least have them in 40 to 60 nanograms per mil before we do any bone grafting or implant placement, okay? When you look at a patient's blood work, vitamin D will be reported in nanograms per mil, or it can be reported in nanomoles per mil. Most of the time it's nanograms, but if it's in nanomoles, it's a very easy conversion factor. 1 nanomole equals 0.4 nanograms, so it's about half. So you can convert it. In order to keep at 40 to 60 nanograms per mil a day, your patient is going to need to be taking anywhere from 1,000 to 4,000 international units a day. Vitamin D is usually measured in international units. It can also be measured in micrograms, and there's also a conversion for that. 1 microgram equals 40 international units, so that's how you can convert that if you ever need to. So what do you think? Are most people deficient? Most people are, yes. And actually, this is a study that is out of Germany last year. This is a really great paper. An oral surgeon in Germany, they're very deficient there. I guess there's not a lot of sun. I've never been to Germany, but I need to be more traveled. But 45% in this paper were below 10 nanograms. That's super deficient. And only 12% were greater than 30 nanograms per mil. So there's a lot of people walking around that are very deficient in vitamin D. It has gotten better since COVID, actually. Like, more people take vitamin D now. And when they come in and we're testing them, a lot of people are actually adequate lately. So that's been one good thing. So how do we supplement for vitamin D? Well, you can have their doctor do it if you want. Usually, if they're going to be placed on a supplement, it's either going to be vitamin D3, or some doctors will put them on 1 pill once a week of vitamin D2. They can get it from their diet, but that's usually not the best source. It's very hard. If they're going to get over-the-counter vitamin D, then they want to get vitamin D3 with K2, okay? That's the best form. That's the most usable form. It goes straight to the liver. And it needs to be taken usually with food, because vitamin D travels in the blood bound to proteins and lipids. And so that's how it's carried to where it needs to go, okay? If the patient comes in and they have on their prescription list vitamin D2, then that means their doctor has prescribed it, and usually it's 1 pill a week, and it's 50,000 international units a week. And that is very adequate. Usually those patients are doing pretty good. Tell your patient to go outside and take a walk. A person like me with fair skin, without sunscreen, I can be outside for 30 minutes, and I'm going to get a lot of vitamin D. The darker your skin is, the longer you have to stay out. Dark skin needs 3 to 4 times the amount of time than light skin. So, and I wear sunscreen, so that blocks it. So I try not to as much anymore, but it's a balance, right? It's a battle. So in the paper, Dr. Gennadi's paper, he has a little protocol, and this is kind of what I follow. So your patient comes in, you find out what their vitamin D is. If they are less than 40 nanograms per mil, then he gives them 10,000 international units a day, which takes sometimes 4 weeks to get them up to above 40. It takes a while. If they come in and he tests their vitamin D and they're between 40 and 80 nanograms, then that's right where we want them. So we're to maintain that, it's 5,000 international units a day, okay? If they come in and they're greater than 80 nanograms, these are the type of people usually that maybe they work outside, they get a lot of sun. These patients really only need 1,000 international units a day, so they don't need as much, okay? Some things that are important for absorption impairment: obesity. It's really hard to absorb vitamin D. Anyone with liver or kidney impairment, because you guys saw that the liver and kidney is involved in the process. And any digestive issues, malabsorption, patients that have had gastric bypass and they can't consume a lot of food at one time, it's hard for them to take a bunch of vitamin D at one time. So these patients are going to be really hard to get their vitamin D up. So you might be thinking, well, I don't really want to do this. I don't really want to tell patients to go to the store and buy all this stuff, and I don't want to buy vitamins. Well, there actually is a vitamin that was made just for this. So it's kind of cool. So it's called Dantomedica, and it's designed for patients that are getting surgery in the mouth, okay? You can even if you're doing tissue grafting, it will help accelerate the healing with that. And what they do is there's a morning bottle and an evening bottle, and they take 4 pills in the morning and 4 pills in the evening. If they do this, they get 6,000 international units a day of vitamin D3. There's other great stuff in there too, like multivitamins, antioxidants that accelerate healing. And they even have a whole little protocol for you, okay? So 1 box is a 6-week supply. And when they come in, say their vitamin D is 20, okay? Not bad, but we like to get a little bit higher. So we're gonna put them on, they start the supplements. If they're healthy and really it's just their vitamin D you're trying to get up, then they're gonna take the vitamins for 4 weeks before you do the surgery. Then you do the surgery and they continue taking them for 2 more weeks. All the other things, if they are obese, if they smoke, if they're over 65 years of age, so this is basically like all of my patients, or if they have problems with their immune system, you give them 2 boxes and they're gonna take it for 12 weeks. You're not supposed to start the surgery for 8 weeks. I don't do that because patients come in and they don't wanna wait 8 weeks. They don't wanna wait 8 weeks to have their surgery. So if I can get them at least taking it for 3 weeks, I'm happy. Now, how do we know? How do we know it's working, right? Oh, I was gonna say, sometimes I'll get a patient that doesn't wanna take the Dantomedica because they take a bunch of stuff already. And they're like, well, I don't want to add that because I already take, resveratrol and coenzyme Q10, and I like those and I don't want to change it. So when that happens, I have Nutrametrics is a company that I've been working with for 10 years, and I actually have a custom supplement that I designed back in 2013 for my patients that have periodontal disease. And I had a whole regimen for them because we do LANAP and we put them on vitamins and all that fun stuff. But anyways, this one is just vitamin D3 with K2. And so I'm like, fine, then just take this. And this one is in micrograms. 125 micrograms is 5,000 international units. So I tell them, just take 1 cap a day. And if they're really low, they can take a cap in the morning, a cap full in the evening, and that would be 10,000 units a day. So this is kind of my go-to if they don't want to take the Dantomedica for some reason. Okay, so how do we check it? Well, there's also a little in-office vitamin D test kit, okay? If you guys go to your doctor and you say, I want you to check my vitamin D, it's really expensive. I asked my doctor to do that for me a couple of years ago. I was like, can you just check my vitamin D? Because he was doing routine blood work, and it was like $260 on my bill. I was like, holy cow. So we charge $42 for this. It's not a big deal. It's not gonna make or break a treatment plan, but it's an in-office kit, and we do a little finger stick and we get the result in 10 minutes. So the way that it works is it's an antibody conjugated test, okay? So vitamin D circulates in your blood, 85% of it is bound to proteins, and then about 10% of it is stuck to albumin, and the rest of it is just free floating. So most of it's bound. So what this does is you put the blood in the little well here, and then you put a buffer right here. And what it does is you let it run for 10 minutes, and it runs down this little strip. And so you see the second picture right there is after 10 minutes, and you can see the 2 little lines on there. And basically, the blood ran over the first line and the second line, and the antibodies stuck to the vitamin D, okay? Then you put this little reader, this little blue reader, on there, and it reads the amount of antibody that is bound. So it's kind of an indirect measurement of vitamin D. And this is how it works. I have a little video. So we're ready to read the vitamin D.
There, I didn't turn it on yet.
And it's telling me that it's doing nanograms per mil. And so this patient's at 40. So this is a patient we had on vitamins, so we always check it before we do the implant, and everything's good to go. So how do you implement this in your practice? It's not hard. It's not hard. Just incorporate it into your treatment plans. I don't care. Raise your implant fee a little bit. Whatever is easiest, however it is to present. It's $42 for a vitamin D test, and a 6-week supply of Dantomedica is $92. That's not that much money, okay, if patients are going to pay a bunch of money in your office. If you don't want to do this, that's fine, but you need to inform your patient that if your vitamin D is below 40 nanograms per mil, your implant is 3 times more likely to fail. And put it on your consent forms. And I mean, we have a form if they absolutely refuse any of the vitamins, which that's only happened once in 2 years, then we give them a form and it's like, this was your vitamin D today. we need you to take 6,000 units of vitamin D3 with K2 in order to get your levels up to 40 nanograms. And we just tell them. And if you don't want us to help you, then you gotta do it. So now we know about vitamin D, but what else can we do to increase our success rate? Well, it's very interesting. So I bought the Fotona laser. I've had the Perio lace, which is Millennium. I've had that since it came with my practice that I bought in 2012. So I'm very experienced with the ND YAG laser, and I use it all the time. And then 2 years ago, I bought the Fotona. I added that to my practice because I wanted the erbium YAG also. So I went to learn about this, and at one of the classes, Fotona has all these classes. It's almost overwhelming. It's like you have to take all these ones. So I went to this advanced perio one, and I learned about this study where they were using erbium YAG lasers in rats. They would prepare the osteotomies in their little, I think it was in their legs or something. And in the test group, they would go back with the erbium YAG laser and just basically punch little holes in the bone, right, and stimulate bleeding. And on the other group, they wouldn't. They just prepare it just like we're doing a dental implant, and then they place the implants. And the results were pretty cool. They looked at bone to implant contacts, okay, which obviously we want that to be high, right? That means it's stable. So at 3 weeks in the test group, the group where they used the laser, bone to implant contact was 59.48%. And in the control group, just the traditional drill a hole, put an implant, it was 12.85%. At 3 months, bone to implant contact in the test group was 73.54% versus 32.6%. That's significant, right? So what's my first rule? Do no harm, right? Is it going to hurt anything to run my erbium YAG laser in my extraction socket or in my osteotomy? It's not going to hurt anything. It's actually, the erbium YAG laser is the hardest laser to hurt somebody with. It's attracted to water, and as long as you turn your water flow up, it does minimal damage. It's really hard. So I do that now. And I was already using my perio lace in every extraction socket, and I'll show you guys how I was doing that. But I've been doing that, and it does seem like, I mean, it's all subjective, but it does seem like I'm getting better results in my extraction sockets. The osteotomy, I'm not going to know, right? I don't know unless I take it out and measure bone to implant contact. I mean, already my implants are kind of integrating, but it doesn't hurt to add it. So this is, with the Fotona, they have a concept called the photoacoustic effect. And actually, Sonia, you might have heard about it because it was actually designed for endo. And so I don't do endo, so I can't speak to that. But so what the photoacoustic effect does is basically, it's all of the energy, and there's water, and it goes and it just transfers all the energy and it cleans out the canal, okay? So this is a video. This is an implant that's got calculus all over it, and it's down. They've dipped it in water in something that has 4 walls, okay? So the energy is going to bounce off the walls. So watch when they do this is the photoacoustic effect. The tip is tapered, okay? So the energy comes out from the sides all the way down to the bottom, whereas if it was just a flat tip, the energy would only come out the bottom. So since it's tapered, it comes out all around. And you can just see like the calculus just kind of flies off the implant. So it's kind of the same effect inside an extraction socket. You put it in there, you fire it, it's going to bounce around, it's going to kind of clean the walls of the bone, it's going to punch little holes and accelerate the healing. So this is what I do. Like this is my laser, this is the tapered tip, and this is what I'll do pretty much almost in every extraction socket, especially if you have like periapical radiolucencies with radiolucent bone. I'm doing this in all of them. And so you basically just run the laser. And I want you guys to watch, like at the end of this video, how, I mean, it's not like the socket's not bleeding right now, but there's a more uniform flow of blood, and it's even from the bone around the crest. And I'm not even putting the laser at the crest. I'm just holding it like at the top, and the energy is bouncing off. And whenever you do this, there's not a lot of protocols in the literature about this, But you just want to leave it in there less than a minute. You don't want to overdo it. So, yes, exactly. You want it to bleed, right? Yeah, no, it's great. And I'm going to talk about that in a minute. So, it's almost over. Sorry. It seems so long when you're standing up there and everybody's looking at you. And it's just micro holes. It's not. So my assistant, she's gonna suction because she's like OCD about blood. It's a problem. Sometimes I'm like, it's okay, leave the blood. You see how even like the bone at the crest right there is bleeding? It's just all uniformly bleeding. And it's just like, for me, that's just like a beautiful thing. I love it. So what you were talking about, how many of you guys know about these drills, these osseo, the condensing drills? They're great, right? If you want to use these drills, I highly suggest you learn about them from the actual manufacturer, because what these do, most of the time you're going to use them is in the posterior maxilla, and right, that's our highest complication rate. Well, what they do is they push, they don't cut bone, they push it in all directions, up and to the sides. It's great because you have that type 3 bone and you can condense it a little bit, but you don't want to condense it too much, because what you do is you basically smash the blood supply. And when I first started using this, I had some failures and I had to reevaluate my protocol. But this is a great thing. You can put your erbium YAG laser in there if you feel like, you can feel when you over-condensed if you use these enough. It's like there's a lot of vibration and you're like, I don't like the way that sounded. So sometimes I'll go back, like let's say I'm placing a Straumann and then I've got my Densiburs and I've used the 3mm and it feels too much. Then I'll go to the Straumann kit and I'll use the burr that actually cuts and I'll cut. And so it's an art. So if you want to use these drills, please talk to somebody who is already using them, or call me. I'll kind of walk you through it, or go to the course and actually learn about them the right way, because you don't want to have failures. It's not fun. So the other thing that I do with the lasers, I love lasers, they're awesome. But so I've had the PerioLace, and you can use the ND YAG laser as well to accelerate healing. It's called photobiomodulation therapy, PBMT. Other things that it's called that you might have heard are biostimulation. Have you guys heard of cold laser therapy? A lot of people have heard of that. Low laser therapy and laser therapy. These are all the same thing. What it is it's 1064 nanometer wavelength. You can also get it in the 900s, but there's some at-home, that's what they call like the red light therapy. It's usually like a 900 and a 600 LED together. But what it's doing, does anybody know what this organelle is? Do you guys remember from biology? It's the mitochondria. So what it does, this is the short version because it's a really long explanation, but basically it's exciting the mitochondria to increase the production of ATP. So ATP is needed for everything that our bodies do, for healing, everything. So if you increase the production of ATP, you will increase the body's healing defense. So how do I use it? In the mouth. Well, it's going to accelerate my healing. I already said that. It's going to minimize inflammation and pain. It kills harmful bacteria. It actually goes into the bones. If you have radiolucent bone and you just kind of dap and touch with the laser, it starts to kill that, and it stimulates bone formation and healing. It stimulates the body's natural response, and it helps increase circulation, okay? So in this case, this one's kind of short because it's not a bad socket, but you basically just kind of bounce around in there. And what it's doing is it's just kind of accelerating the healing. It starts the blood clot formation, okay? Here's a video of, like, I took a tooth out and then I just treated the extraction box. There's music because it was on my Facebook. So you bounce around, you touch the bone, bounce around a couple times, and then you come up and just hover, and it literally turns into like an over medium egg. And the blood clot forms right there. It's not cauterizing, okay? Cauterizing is heat, it's death. It's hemostasis. It's different, okay? great. Patients are on Coumadin, things like that. Send them home, the blood clot's already there. If they lose it, it's their fault. I'm just kidding. So the settings, if you do have a perio lace, you probably already know this, but it's ND-YAG, and usually it's delivered via a fiber, and it's 550 microseconds, 3.4 to 3.6 watts, usually just for about 200 joules, okay? It's not gonna hurt anybody. So my full protocol, basically, like if somebody comes in and they have a tooth like this, like a failed endo, maybe the tooth is fractured, there's no way I'm gonna place an implant the same day, you know, we're right next to the sinus, so I don't even know, sometimes I don't even know if I wanna put a bone graft in the same day, right? I mean, if they have a really thick buccal plate, that's great, because I might just clean this out really good and put PRF, and then come back and do the implant in 6 to 8 weeks. But this is, I took a video, so this is like my full protocol if something like this walks in my door, okay? So I take the tooth out, and you can see in this video, this patient has a really great buccal plate. So that's good, because that means that more than likely, we're gonna be able to do the implant in about 3 months. So this is my erbium, so I'm just putting it in there, and it's doing the job. You literally just hold it there. And then, now I'm doing my ND-YAG. And sometimes I'll even like bounce around the adjacent teeth a little bit, just to make sure that the bone is nice and hard. And then something else that I do in a case like this is I'll put PRF in there, and it has all those great leukocytes and growth factors. And here's the PRF. These are the membranes. I do the full membranes. You smash them. In this case is not this x-ray. This case, there was a communication with the sinus. So that's why I didn't put any bone graft. So I put a lot of PRF up in there. Just put it in there, and then I just did a figure 8 suture. And she actually came back in 6 weeks. It was totally healed over, and it looked great. So in 3 months, we were able to put an implant in with no bone graft. It filled in with bone on its own, mainly because she had a thick buccal plate, and because the area was cleaned properly, and because we put growth factors in there that accelerated her own body's response. So that's what we do there. And then I think I have my sutures. And then I put this one in here just so you guys could see. I've started placing ceramic implants. They're great, they're beautiful, they look beautiful in the anterior. If you want to start placing ceramic implants, please call me before you do. Don't listen to your rep. They're gonna be, it's fine, yeah, just go ahead, it's the same thing. It's not the same. This is the socket that I just treated and cleaned out really well, because I get very nervous doing immediates with ceramic. But with ceramic, it is a little bit different. There's no custom abutments or anything like that. So your timing with this implant system, this is a 2-piece, and your timing has to be right on. That little crosshair has to be on the buccal. So in this video, I'm trying to get it on the buccal. And the other thing that's very interesting about ceramic is you don't want to go over 40 Newton centimeters. Those of you that place implants, when you're placing titanium implants and you're like, oh, maybe this is a little tight, it starts to squeak. You guys know that noise, like when you're putting it in with the torque wrench and it's like, great, great. These start to squeak at like 40. They go in very tight, so you have to be really careful. And the other thing that's really weird is you actually place them supracrestal, which is like totally opposite of what we're used to. And that's because the stock abutment has a 1 millimeter collar. That's it. So you cannot place it subcrestal. You will be setting the patient up for a lifetime of peri-implantitis. Okay, so maintenance. This is my last point. Maintenance is very important, okay? So maintenance in my office, if they are not an alternating patient and we did an implant, we like to have them back after they get their crown. And what we do is we go over oral hygiene instruction, because a lot of patients don't know how to floss their molar implant. They don't understand that it traps food, so we show them that. We take a PA, so we have a baseline radiograph of how everything looked when everything was pristine. We take the probing depths and evaluate the tissue, check the contacts, check the occlusion. If there's any large excursive forces, I remove those forces. My dentists are really good. I usually don't have to adjust their occlusion, so I'm lucky. And then, if you are seeing them in your office, just take a PA. Usually, after 3 years, you can kind of treat that implant just like a normal tooth. Take a PA whenever there's a problem. 2018 to 2021, these implants have had 0 bone loss. I'm very happy with this. I'm very happy with the stability of this. We don't need to stress out about checking it so much. And also, if you do start to see peri-implantitis or bone loss around an implant, don't wait because it happens so fast. This was in a period of about a year. This patient basically, now there's hardly any bone, so it's much harder to deal with now. So in conclusion, perfect timing, right? In conclusion, we're gonna make sure our patients are at least 40 nanograms per mil, okay? I'm telling you how to increase your success rate. This is very important. We're gonna start a loading dose of an antibiotic before all of our dental implants. We're gonna have a smoking cessation protocol. I told you guys what mine was, 2 weeks before, 2 weeks after, no nicotine. We're not gonna immediate load anything 10 millimeters or less. Whenever possible, we're gonna add extra treatments like photoacoustic effect, PVMT, or PRF to accelerate our healing. Because although the literature doesn't really say it makes a difference, I understand that. Are we doing any harm? No. And when I have a boutique practice in Fort Worth that wants to stay fee for service, I want to provide an exceptional patient experience. And so that's what we do. We're gonna ensure systemic conditions are controlled. Periodontitis, we're gonna ensure that hemoglobin A1C, that's supposed to be less than. We're gonna ensure it's less than 8, or else no regenerative therapy. Nothing fancy until we get all of those controlled. If anybody has any questions, you can ask me now, or you can email me anytime. This is my email. I'm very responsive. Or if you take me out to lunch, I'll probably give you my phone number and you can text me. Yes. Yeah, you can do that too. I just like to use the actual system drill because, I don't know, I've used those and I feel like the 3, if I go to the 3 and then I'm gonna place a 3.3, I feel like I don't get good stability sometimes. So sometimes I'll go back to the actual system because I feel like it's more accurate. I just do that.
So versus their symposium, they said that when you press it, people think that it's less blood supply, but they were stating that it's actually more blood supply.
Really? I don't know, that was not the experience I got. And I had some failures with them, and when I started, maybe not, because, if you do the sinus lift protocol, you're supposed to go straight off the back. You're supposed to go boom, boom, boom. And I think that's too much. So I skip around a little bit, or I'll cut a little bit. I just don't really, and I only use them in the posterior maxilla. I don't use them in the mandible. They're too much. So they are great, though. They are great when I need them. They're great, but they're different. You have to really understand what's going on. It can be the heat, too. It can be the heat. You need to you have to slow it down and make sure there's copious irrigation, for sure. No, we don't keep it in the fridge. Yeah, but if it's not hitting the drill, it's not hitting the drill, It doesn't matter if it's cold if it's not hitting the drill.
One assistant usually, at the end of it, we design the guys that have a shallow end so that it comes to the top, and then the bottom gets it in the drill.
Yeah, you have to do that. You have to make sure it gets irrigated. I mean, that's why but I think a lot of people weren't doing that when guided first started, I honestly don't do a ton of fully guided. I know that maybe I should stay and listen to your talk, but.
It's got to be a little deep for me to do guided.
yeah, I use a lot of guides, but I don't do a lot of fully guided. But that's just me. That's how I work. Any other questions?
All right, guys, let's give it up to Dr. Nelson. And Shelby, I would like to present you this plaque as an appreciation for being here today to share your knowledge with all of us. Thank you so much for all your contributions. And as you know, Dr. Nelson, wherever he speaks,